I just thought I'd take this time to mention a couple of things. So we've got 2 webinars planned for next week, which are looking to be absolutely fantastic. We've even got Chris Barrow joining us again next week for a really interesting discussion about pricing in the new world of dentistry. So at the end of the webinar today, I will give you more details about the upcoming webinars as well. We've also, as I'm sure you're all aware, but that most of you have tuned into some of our webinars recently, so you're probably aware that we were running a really fantastic offer on membership throughout May, where you can save £600 on your membership. So a lot of people were jumping on board with that. We've had a huge influx of new members taking us up on that offer, so we have decided to extend that into this month. So if you are still considering membership of iComply and you want to access those fantastic documents that Alex and the team have put together for your SOPs and things like that, then give us a call. There's also a little pop-up on your screen any second now that shows how you can book a free demonstration of our services if you want to just find out a bit more. There's obviously no obligation if you have a demonstration with us. It's a case of just finding out what we offer and if it's suitable for you. But as I say, that fantastic offer is still running. So without further ado, I'm going to move on to the next phase of the webinar. Yeah, there we go. Okay, so I'm going to introduce our guest today. So we're taking a look today at getting your practice back on track, guidance from the experts. So we've got a fantastic panel of people joining us today for the webinar who have different areas of expertise within this industry and within this field. So we're going to be looking at various different angles today. Obviously, what we're going to be discussing today is guidance and regulations, but we're also going to be giving everyone a chance to talk about their own experiences, how they interpreted things. So it's a real open discussion today. So I'd just like to welcome our panelists. We've got, first of all, Rebecca Sadler, who is the Director of Clinical Dentistry with Portman Dental Care. I'm sure I don't need to say much more about Portman, but just for anyone who doesn't know, Portman are a group of practices, I believe over 130 sites now, founded in 2009 with really, really strong culture and values. They've been very prominent through the COVID scenario as well, publishing their standard operating procedures for the industry to take a look at and things like that. So we're really excited to have Rebecca joining us today. We've then got Stephenie Malone, who is the legal director at Harrison Clark Rickerbys Solicitors. For anyone who's not familiar with this solicitors firm, it's a top 100 UK law firm, and Stephenie is actually in the health and social care team as an employment law specialist. And then someone who probably doesn't need an introduction, but I'm going to do it anyway, is our very own Alex O'Neill. He's the head of compliance here at Code iComply. Many of you have probably spoken to him. If you haven't, you would have, I'm sure, seen him at our live events and webinars. Obviously, coming from a family of dental professionals, he's grown up in the dental industry. He has years of experience in practice management and business consultancy with practices, and he's been actually working with Code since 2014, creating the systems that we use and implementing documents and guidance to help our members. So that's our panel today. I think you'll probably all agree that it's a really interesting group of people that we have to discuss the next phase of going back into practice. And what we're going to do is just, we've got a few questions that we're going to run through. These are sort of the most asked questions, not only to Code, but also some of the most asked questions that Stephenie's been getting recently. So we thought we'd run through these, just get everyone's opinions on this, and then going forwards, we'll open up to a Q&A at the end as well, and we'll be able to take some of your questions and go through those. So first of all, I'm going to actually go straight to, for this question, I'm going to go to Rebecca first of all. It's basically, there's a lot of guidance out there at the moment. I'm a practice manager historically, and even I am struggling to get my head around a lot of the guidance out there, and it is conflicting and very confusing. So how would you recommend trying to make sense of the conflicting guidance from the CDO, FGDP and NHS?
Hi everybody, thanks for joining me on your lunch break for some. I apologise, I'm in my scrubs because I'm in clinic today and I've been seeing my patients this morning, so it's kind of quite exciting and frightening too. It's a bit like coming back from maternity leave, like kind of remember what to do, and actually after the first one it was kind of felt very normal. This is the $24,000 question, isn't it? And I think the honest answer is we've got a big clinical team at Portman, and for the 10 weeks that we've been working our way through the COVID crisis, we've spent all our time analysing, reading, rereading, rethinking and discussing. And I think the clear answer to this is, in my opinion, I don't think there is one definitive. I don't think you could say, I'm going to take this bit of guidance and that's absolutely the kind of gold standard. I think you have to make your own individual opinions based on the guidance that is out there and based on the regulatory body that affects you. My understanding is most of us on this webinar today are working in England, but obviously we have to accept the fact that the guidance across the 4 nations is slightly different, and we're all at different stages of the pandemic with different national guidance. So you have to think about those. And Portman as a group, we've got practices in all 4 nations. So we've had to try and marry the kind of evolving guidance as best we can to a kind of unified approach. I think one of the things that's really important to remember is what is the difference between regulation and guidance. And funnily enough, Alex and I were just having a bit of a banter about this before we kind of went live. It's really difficult because I think for the regulators, for the guidance, and for us as individuals, we are operating in a world where there is very little evidence, and so people are trying to devise guidance on the back of, in some areas, very limited evidence, and in some areas we've got to try and apply evidence in different models, so SARS, to make pragmatic suggestions. So I can tell you how we've done it in Portman, if that helps you. We started off by reading all the regulation. So I would always start, my one overriding thing is you've got to follow the regulators. Yeah. And in every single one of these guidance, they all say you must follow the underpinning guidance behind it. And I think it's a very commonly missed kind of lead point. So for example, every single one of them refers back to Public Health England, or they refer to HSE for respirators. But it's very easy just to take the top document and go, yeah, well, I won't read the 20 links in it. You've got to read every link, and you've got to understand the guidance, the regulation behind it. Because it's very easy to read one sentence, and I'm going to pick a controversial one, or, oh, it's fine for sessional use. If you haven't read the 20 documents that go behind that to know when that's applicable and when it's not, you might find that when regulators come, you might be indefensible. So my overriding was read the regulations. Then you've got to pick the guidance, and we read every bit of guidance that comes in. I spend every living hour, I'm not with the patient, reading the latest bit of guidance, and it's always changing. And it's different whether you're the British Orthodontic Society or the British Periodontal Society or the FGDP or the CDO of Scotland or England. It's all different. And so you have to read it carefully. And then I think you have to make your own evidence-based risk assessment on the guidance and your individual situation. We're a big corporate. We're always under the spotlight. So regulation comes first. We absolutely have to go to the highest common denominator. What somebody might choose to do on a local level may be different to that. But I think it's important to read regulation first, then guidance, and then make your own risk-based assessment on that. I know that doesn't give you a definitive answer, but I hope that helps as a start.
Yeah, absolutely. It's fantastic to just get a little bit of insight into how Portman are taking a look at that. Alex, is there anything you wanted to add to that? Okay. Just
unmuting my mic. I'm going to echo Rebecca, even with the introduction of saying hello, everybody. As always, great that people have taken their lunch times to come and listen to us talk about stuff. So it's really nice. I have a list here that I've been making notes in, and to be honest, pretty much all the points are exactly the same as Rebecca's. So there's not really much that I can add to it. I'd say that I think there are conflicts in the guidance. I'd say the majority of stuff, I'd say, is similar or the devil's in the detail, right? And that's what it's coming down with these SOPs and with the guidance. And I think that almost taking a step back and echoing something that Rebecca said, but in a different way, is everyone's always looking for the quick fix. And we're going to get onto the SOP question in a bit, but everybody always wants to know, what policy do I need to run a dental practice? Or what procedure do I need? Or what SOP? Or, you know, which
I'm definitely
guidance?
guilty of that in practice.
Me too, absolutely. You know, and I'm very much like a D-type personality in that I want it now and I want it done. So I'm very similar in that way, and a lot of managers are that personality type. I try to, you know, right now is the point where you've got to get the knowledge. It's all based around the knowledge of basically what are we doing right now? We've got to reduce transmission. That is it. So you've basically got to figure out how that works. I'm going to talk about more of this in more detail on the SOP question because it's more relevant, but it's about getting the knowledge, and that starts with reading. As a practice owner or as a practice manager, everything's been pretty solid for so many years that if you get a policy template from someone like Code and follow it, you're probably going to be okay with minor adjustments. Right now, it's kind of time for managers and owners to step up and to actually understand everything that is, because this is so pervasive. So just running through my notes, I've just said I'd tried people. It's definitely confusing. There are conflicts there, but I'd try not to think of it as conflicting. I'd try and think of it as filters, right? So if you took something like regulation as the base and then faculty guidelines as lying just above regulation, this is where Rebecca might disagree with me, but then your NHS national SOPs are your next filter level, and then your regional SOP is your final filter. If you go through that process of reading, by the time you get to the last SOP, you know what you're talking about, and you're like, oh, well, they're saying that's how they're defining a session. Yeah, I was actually looking into this last week over the sessional use, so it's quite funny that Rebecca mentioned it, but what's a session? Well, in dentistry, is the session the morning, or is it the moment you step into the clinical area and then walk out of it? So there are those sorts of granular points. So I would, you know, I'd look at it in that way. And then the interesting thing is probably your regional guidance, your bottom level, as it were, or your final tier, whether that's your London SOP or something else, if you're a different country, that's kind of your final filter, and that's mostly what you want to be following. So hopefully that answers the question, but you've got to throw a bit of common sense in there. If the national thing is really restrictive and your local SOP is saying, by the way, guys, full routine dentistry, all AGEs, then a bit of common sense that could be potentially a typo. Not that would actually happen, but you get what I'm getting at.
Absolutely, thank you. I'm going to, because you've touched upon the SOPs a lot there, I'm going to take us on to the next question, which is all around standard operating procedures. So we're asking the question, what new procedures will I need to implement? I am really conscious as well that in the Q&A we've got a lot, this is where most of our questions are coming from at the moment. So there seems to be a lot of questions around AGP in non-ventilated rooms, and also not being able to get hold of certain PPE and what's necessary. So it might be worth just incorporating that into the answers. But if I'll actually start with you on this one, Alex, because I know it's an area that you've been looking at a lot recently. Oh, you're on mute at the moment. There we go.
I'm so not used to muting myself during these webinars because my mic's usually normally on, so I just forgot that I was muted. I think it's a really good question, but it's potentially the wrong question to be asking. And it's very similar to the sort of pre-compliance, what policies do I need to run a dental practice, when the question you should be asking is, what regulations do my policies need to meet? Or what are the rules that my policies need to meet? So I think it's potentially the wrong question, or more precisely, it needs extending to something like, what procedures do I need to implement in order to meet the guidance and reduce transmission? Now, I could sit here and give you a list and say, you're going to need a PPE donning and doffing, you're going to need this, you're going to need that. That list is in iComply for our members already, but that's our interpretation of how you meet the guidance. And there's many ways to skin a cat. So going back to what I was saying before, it's more important to understand what you're doing and do that reading that we were just discussing, and understand that the SOPs that I think that the NHS titling those documents standard operating procedures is quite misleading. It's guidance to help you write your standard operating procedures. So similar to the stuff that we've just put in iComply is not guidance. They are standard operating procedure templates to be edited after you've done your reading. And you know the key decisions that you're going to make. So you know you've got to look at that patient journey from start to finish. That's all this is about. It's literally, apart from a few bits with your staff, well, actually, that's probably oversimplifying, but I'll talk about the patient journey side. Essentially, what you're dealing with is from the moment the patient picks up the phone to the moment they leave your practice, that entire journey, how do you minimize transmission? How do you minimize aerosol transmission through AGEs, non-AGEs, contact transmission, people touching stuff, and droplet transmission, people coughing, etc. How do you minimize those things? You're going to get those rules from that reading, and then you use that to edit and implement your SOPs to reduce the transmission. I've missed out the point there that there should be obviously a comprehensive risk assessment that you do kind of after your reading, but before creating your SOPs. Okay. And we've got a document in iComply, which is the one you were talking about before, actually, Sam, C201. Which basically comes down to the decisions people need to make. Now, the last thing I want to sort of almost say on this is, right now we're creating SOPs for what is essentially a phase 1 relaxation. Those are going to have to completely change when we hit phase 2, when we hit phase 3. So there's going to be differences. So you've almost got to understand the constituent parts of your SOPs, as in, what are the PPE requirements right now for this phase with this evidence? That's one table you're going to need to write in your SOPs. What patients am I accepting? Am I accepting category 1? Probably not right now. Category 2, shielded. We're supposed to avoid them, but if we are having them in practice, when are we booking them for? Category 3, pretty much we'll see any time. All of those rules, those bits are going to change when the NHS release their next guidance or in the next phase. So as much as you can understand, those are the core parts of your SOP. Those are the key decisions, and I won't go through all of them now. I've given a few examples. Those are the key decisions. Once you've got that knowledge and you've written your first SOP, when the next lot of guidance, the NHS SOPs, which I'm going to call guidance, come out, or whatever happens, or the evidence base changes, and we find out that we can reduce fallow time, then you're going to be able to edit that bit of your SOP and tweak that procedure. And sorry, the last bit I'll say about it is it's not just about creating the SOP. You've got to make sure that you train your team, you do scenario-based training. We were talking about this before the webinar, but role play a non-compliant patient who decides they're going to go off and use the toilet, or they suddenly have a cardiac arrest, and see if your team are using the new Resus Council approach to CPR and they're not doing the old way. So you've got to sort of get that stuff documented as well. So I know that's a long-winded way of hopefully answering the question, but I hope I've touched upon all the main points there.
Yeah, that's fantastic. It really, really insightful. And I can see in the Q&A, we're actually getting a lot of people asking about, in particular, what procedures Portman have adopted and implemented. I think Portman are definitely leading the way on a lot of areas, and people are looking to them for a little bit of structure. So if there's anything that we can add on that, Rebecca, that would be great.
So I think the key thing about what Alex said, which would kind of reflect what I said at the beginning, is I think you do have to create your own SOP. I drafted, along with a team of brilliant clinicians and other support members, our SOP actually several weeks ago on the basis of the evidence that was available then. We're now on version 3. I suspect by the end of tomorrow we might be on version 5, the pace of stuff that's coming through this quickly, because you have to be constantly staying abreast of the changes that are coming. But I really agree with Alex that it's not just a case of you read one thing and you go, oh, okay, this is the new, this is what I'm going to follow, because you've got to consider all the evidence base behind it, or lack of, or consideration. So I can kind of help a little bit in the fact that we started with the rules and the regulations, and then we kind of layered on top of that the kind of practical realities of trying to apply that to dentistry, because quite a lot of those rules and regulations for COVID have been written for healthcare settings as a general rule. So again, if you read the implications of how the interpretation of how things are written, they are written. So I'll give a good example. Again, sessional use has been applied to a ward setting. That's what it was written for. It wasn't written for a closed room individual dentist scenario. And so you have to interpret the rules and regulations and the thought process behind how they were written. And then you have to decide on your own local requirements. So I know that our SOP is in the public domain, and we've had no concerns about sharing that. it also is different to lots of other groups and lots of individual ones, because we have had to take our own levels of interpretation. And I know that we have set some things. I get questions from clinicians, lots of them going, this is brilliant, you've taken a really safe stance and we feel really reassured to be working in this environment. And you always get one who's going, well, I think it's fine just to wear a fluid resistant mask for everything.
Yeah.
Why are you over here? And I think I've got to be able to sleep at night. I've got to feel confident that we're keeping our patients safe, and this is, and our colleagues and our clinicians safe. And it is about minimising disease transmission. I think we know that it is not risk-free. Dentistry has never been risk-free and never will be risk-free. Crossing the road isn't risk-free, but it's about making it as low risk as we possibly can, whilst being able to deliver the care. Great example this morning. I've been remote triaging one of my vulnerable patients who's desperate for me to stick something back on the back of his mouth. He's not in any pain. He's not got any concerns. The risk benefit means I am not going to see him. I don't think, as a vulnerable patient, he should be brought into practice at this point. But he had an appointment at the hospital last week for a much higher risk medical procedure, because the risk to him, if that wasn't dealt with, was much higher. So it's always about looking at each individual circumstance and applying your SOP to that. Policies and procedures, I agree with Alex. You need to look at your whole patient journey. So we had to rewrite our SOP, and we did a full clinical review after the launch of the FGDP document a week and a bit ago, or 2 weeks ago now. No, a week ago. And we completely reviewed, God, I feel like I've done a year in the last week. We completely reviewed our SOP against the FGDP documents. We did that as part of a clinical advisory forum. We agreed. So a good example of that is the pre-medication mouth risk. They state that there's not much evidence. When we originally put it in our SOP, we knew there wasn't significant evidence behind it. There's evidence for providine and nasal sprays, but when you look at the pragmatic decisions of it, it's disgusting. You wouldn't want to do it. I don't really want something squirting up my nose. And you look at the risk evidence and how it perceives to patients and to colleagues. We decided that from risk benefit analysis, we've kept ours in our SOP because we think there is a place for that. Lots of people will interpret that and go, it says there's no evidence, I'm not going to put that in. That's fine. I think you just have to be able to rationally explain your decision-making process. Another good example is the temperature checks at the door. We still do those because the guidance said there was maybe a place for colleagues and not maybe a place for patients. My interpretation and our clinical advisory forum interpretation of that is that we think that they have stayed in. But I agree with Alex, as the phases move down, as we move out of level 4 to level 3 to level 2, some of those things will then be removed. And then we have to completely re-review our SOP again in light of CDO England's on Thursday, and then the UDC update on Friday, and then the BOS update yesterday. But we review it and we consider it before we make another change, and we do the background reading and we look at what we've got to do. So I've had emails pinging in all morning this morning going, what are you doing about the stuff that came yesterday? I'm going, I'm not doing anything yet. We need to wait. We need to do a risk assessment on it. We need to read it. We need to apply it to SOPs, and then we'll come back to you. Because you can't just take the latest piece of paper and go, right, this is my rule book today, because it'll be different tomorrow and it'll be different the day after. Yeah. And you've got to be able to justify the decisions that you make.
Absolutely. And I think where we take a lot of calls from our members and people working in practice, receiving these emails and getting the alerts from different regions. Quite often people hear something from a colleague which they haven't even seen themselves. And it is really easy to hear that and go, oh my God, we need to do something about this now. Oh my God, we need to change that. And I think that's a really important point that you've made there, Rebecca, because actually taking a step back and giving yourself time to actually digest that information before you act on it and actually really assess what it means to your practice is so crucial to making sure that we don't do things unnecessarily. So that was some really good feedback from everyone there. And I can see in the Q&A we're getting a lot of questions surrounding staffing. So I just want to assure you all that we've got plenty of questions that we're going to be covering on the employment front in just a moment, and we will get back to you on the Q&A as well at the end. So I'm just going to move on to our next question, which is our last sort of clinical based question, and it's referring to treatments in the practice. This is an area that actually I find really interesting myself, not yes, I've been a practice manager for many years, but I'm not from a clinical background, and this is an area that I have found very, very difficult to get my head around. So it'll be great to get some insight from yourselves on what treatments we can actually do now, or be booking into the practice since the 8th of June. If I can pop that over to you, Rebecca, first, that'd be great.
So again, I think this depends on your own individual circumstances. And as an example, we've got 138 practices, and for example, we are allowed to see patients face to face in Northern Ireland and in England, and Wales to a degree never really changed. They were allowed to see face to face in theory all the way through, but in a much pared back. And Scotland it depends if Scotland's a bit diverse, but the treatments that you can do in each of those 4 nations is different as of the 8th of June. So I'm going to answer the question, I think, for England, if that's okay, because I think that's easier. So again, absolutely. On your interpretation of the guidance, you could see any treatment, routine or emergency or urgent, within your internal risk assessment. So there are some bits of the guidance that would imply we should be doing nothing other than urgent in level 4. And there are some bits of the guidance that clearly state if you are appropriately protected and you've done your own risk assessments, you could be doing more than that. We have some practices that are doing AGP as of this week, because we have the PPE in place and the fit testing is done and their risk assessments are such that they can carry out those procedures. I'm still in the non-AGP phase in my practice because our fit testing is coming later in the week. So we are doing kind of urgent, and we are prioritising our patients again from a risk assessment of the patient, so the vulnerable or non-vulnerable groups, risk assessments of our staff and colleagues, and then a risk assessment of priority of need. So by nature, the people that have emergency or urgent latent need are the ones that we are assessing and dealing with now in priority of those that need something more routine. But that has been our interpretation of the guidance from the 8th of June in England.
Perfect. Alex, is there anything that you want to add to that?
Not really, to be honest. I think Rebecca's covered pretty much all of it. The only thing I can really sort of say on it is that obviously the guidelines that you're following, whether it's faculty or the CDOs, will say roughly what you should be doing and shouldn't be doing. There are the lists of, essentially we're in a phase 1, the general thing is in England, we're in a phase 1 relaxation, which in a nutshell is supposed to be ideally non-AGP emergencies. That is pretty much where we're supposed to be. We shouldn't really be doing routine examinations right now, but as Rebecca said before, it's down to the risk assessment of the clinician of the patient. The clinical triage stage is super critical right now. In that, if you're not really supposed to be seeing shielded patients and you're not really supposed to be doing high risk AGEs, but if you have a patient who is shielded and the risk to them is so extreme that you really should do the treatment right now, because if you don't do it right now, then the consequences further down the line would be awful for them.
Yes.
Then you book them in and you do a very quick AGE on them. Rebecca's obviously a clinician and I'm not, but if based on that risk assessment, you're looking at the patient and going, well, this doesn't fit the exact rules right now, but then all the faculty guidelines and the NHS guidelines give the clinician the clinical judgment that they rightfully should have. They are professionals,
yes.
So they are intelligent, clever professionals who know what they're doing, and they can look at this stuff, look at the guidance, and go, this patient is shielded, but I need to see them right now. So I think that's all I'd really add to it, is just that discretion bit.
And I'm just going to throw a little bit of a curveball here, because this is a question I've been asked a lot in the last week, is practices that are purely plan-based. So they only have dental plan patients. We've got a lot of people, because they're private, so they're not having to adhere to the NHS side of things, and their patients have been paying for their monthly outgoings onto the dental plan. What would be your opinion on that? Would they be able to do checkups or routine examinations?
My personal opinion is you'd struggle to justify doing routine examinations right now. I think I don't think in your risk analysis you can use the fact that they're paying plan patients in that equation. Rebecca might have a different take on it, but I think that the struggle right now is that obviously a lot of those plans are care plans, not care plans, maintenance plans. They're like 2 and 2 plans. So you've got a contractual obligation that you're supposed to be fulfilling. But I think the main thing I'd say to everyone is just right now you pretty much can't use an ultrasonic scaler, and some of your patients may want that, or you may be paying for you may have a plan that includes air polishing and all of these things. If you can just get your patients to wait, these things will be possible again, and how you manage that waiting period is the key thing, which really depends on your practice, your makeup, your strategy, what you want to do. So I'd say that's how you deal with those patients. I'd rather give specific advice to a practice one-on-one, which I have been doing to our plan members, rather than give a general piece of, the general piece of advice is just manage the expectations around there and try and keep the income. Yeah, brilliant. Excellent. And I'm going to just move on to the next question. Actually, Stephenie, I'm going to ask you to jump in first on this one, but obviously at the moment there is a whole world of questions surrounding the staffing of a dental practice. We know that the general day in a general dental practice is going to look very different, usually longer hours and different procedures. So a lot of people are asking us at the moment, how do I tackle the staffing issues that we are facing? So if I can pop that to Steph. Oh, there we go.
Hi, welcome everyone to the webinar. So yes, there's lots of things to think about here when it comes to staffing issues, and I suppose to emphasise what we've been hearing from Rebecca and Alex, that again it is very much down to individual circumstances when it comes to the staffing issues that a practice may be experiencing, and also down to the individual employees. So it's not a scenario whereby there's necessarily one size that fits all, but in general, the sort of main issues that I'm seeing with regards to staffing as we re-emerge from COVID, because I suppose we all need to remember that whilst we locked down and it was crazy and it was madness, it happened very quickly, and there was only one thing that we really had to think about, which was how do we shut down efficiently and effectively and go into the real sort of emergency processes and procedures. Whereas now we're looking at, as you've talked about, having those different stages and phases, and that's going to mean that your staffing issues are going to be changing, because your practices, perhaps if it's NHS practice or mixed practice, you will have been operating at some degree potentially through the pandemic, but possibly not with all of your staff. And you need to therefore think about who you need back and when, and how you're going to go about bringing them back. So in the same way that you may have conducted an exercise to work out who you needed to keep operating the practice, if you were indeed open, you need to think about who you're going to need at the different stages of re-emergence. So with regards to how you go about that with your staff, you're going to need to look at what procedures you're going to be offering, and as to how and when and the hours that you're going to need for those procedures to be offered to your patients. So if I take perhaps the hours point to start off with, that yes, potentially staff are going to be asked to work longer or different hours. So the starting point is always going to be looking at your contracts of employment and seeing what degree of flexibility you have with regards to changing staff hours. Do you have defined hours for shifts, or do you have a little bit more flexibility, for example, number of hours per week? And as to getting in contact with staff early and talking to staff about what's available and asking them what they can do, because there's two stages to this really. Yes, we may well have the need for staff to come back, but are there any restrictions to prevent them from coming back to the practice? Like Rebecca stressed, I'm talking about the position in England, because that's very much what from an employment lawyer I'm focusing on at the moment, the position in England. But the two main areas that could be a barrier for your staff coming back are if they are shielding, or if they've got issues with regards to returning because they are in a household with somebody who's extremely clinically vulnerable. And the other main issue is those who have childcare problems with schools remaining closed. So it might well be that you're really fortunate and that all of your staff will be ready to come back, available to come back, looking forward to coming back. But for many practices, there will be a number of staff that have got individual circumstances that make it more difficult for them to return. There's going to be a balancing act between what you need and the staff resources that you've got. So early conversations with staff and taking into account that they are going to have their own individual circumstances. So it's not as simple as having an open Zoom call or sending out an email or a text message, or however you're communicating with your staff, saying exactly the same thing. You're needed, this is the time you have to come back, and that's it. It needs to be far more in depth and individual, so that you're taking staff through what's needed. And your staff are also going to be aware of all of the compliance issues that you've been talking about this afternoon. So they're going to want to know how that's going to fit with the work that they're going to be asked to do. So as practice owners, you're going to need to be responding to those legitimate concerns that the staff members are going to have. And it might be that you're able to have some Q&As with your staff on a group basis through platforms such as Zoom, or it might be that you're able to pull together the opportunity for them to have a breakdown of some of the policies and procedures. You're not necessarily going to want to go through reams and reams of documentation with them, but what can you easily disseminate to them to enable them to understand and have confidence in what's going to be asked of them, and also legitimate concerns over health and safety, and as to how that's going to operate for them. One of the things that I've seen is really useful for getting staff back, and it may well be that many of you have been doing this for.
Oh, I think we may, for some reason, we may have just lost Stephenie. That's okay. What I'll do is I'll just open that question up to our other panelists while we wait for Stephenie to join back in. Rebecca, is there anything that you'd add to that that you've experienced with Portman at all?
Truthfully, probably not. Apart from the fact that I think I would agree with Stephenie that it's about an open dialogue with your teams, and maybe we've been lucky, but we seem to have had incredible flexibility and willingness and accommodation from clinicians and colleagues, and the challenges of where somebody can't, from a risk-based assessment, how we manage that. But I don't think I'd have much more to add, and it looks like hopefully Stephenie's coming back.
Absolutely. And I think just to add on that, just from seeing on LinkedIn and various platforms, that Portman have been a real shining example of how to keep in touch with the team with regular webinars and things like that. And I think that has been key. All of the people I've spoken to, certainly, where they said that they've got a team of willing people to come back to the practice, is usually because they've been having regular meetings and even to some degree social events that they're arranging virtually as well. So I think that's a really key point to keeping everyone on side and keeping everyone feeling comfortable. I think we've all probably experienced the when you go away from work for a week or 2 weeks and you almost have that sort of sense of fear of, oh, what have I missed while I've been gone? What's happened? What's changed? And really, we've been gone for a long time. Practices have been closed for a long time and a lot has happened now. So just by keeping in touch regularly, I think it's really crucial to make sure that your team members aren't feeling that fear and anxiety. What's your thoughts, Alex?
The only, just complementing what the other two have said, which has all been absolutely spot on. I just sort of tying the conversations that Rebecca and I were just having with everyone with what Stephenie was just saying. You know, you can only really convince a team if a team member's reluctant to come back and you're trying to explain to them what you've done. You can't just say, "Oh, I've put an SOP in place." You know, having done that reading and got that and having that knowledge, assimilated that knowledge in order to create your SOP is going to enable you to be speaking to these team members from a position of knowledge, to give them reassurance if they're wanting to know what you've done and coming back. If you're saying, okay, well, my understanding is it's transmitted in one of three ways. Here's what they are. This is what we're doing about those transmission. We see it could happen here. This is what we've done. In fact, we've gone a little bit above and beyond here. You know, we're using a mouth rinse, even though, you know, it's not necessarily the FGDP doesn't like it anymore. But the things that you're doing, you're going above and beyond guidance as well. So if you're making those decisions, you know, if you're giving the patients mask and gloves, which if I remember off the top of my head, the faculty guidance doesn't say you need to do that. It says you need to have the hand sanitization stations. But if you're doing that extra bit, oh, by the way, you know, we're giving everyone masks and gloves, so we're protecting you even more. So if you've done your reading, you've got the knowledge, then and you've created your SOP, then it's going to enable you to have those to have better conversations with your team.
Absolutely.
And I would build on that, actually, that to the point that I think my poor colleagues are sick to death of us on their webinars, and I think they're like, oh no, not again. But I mean, it's one of the benefits of being part of a big group. But as part of my advisory board and group in writing the SOP, I had a nurse, I had a hygienist, we had several PMs. So it was really important, I think, to involve the wider team in the creation of what you're making, because dentists are notoriously analytical, narrow-minded, and we only see it from one perspective. And I'd got, let's say, 90% of the way through our SOP, and when I got my nurse's input or the nurse's input, they looked at it from a completely different standpoint and picked up things I just never considered that were, if I'm honest, probably even more important. So I would genuinely encourage people to get their team's input and thoughts. If people have felt like they've been on the journey with you, they're much more willing, as Alex has said, to kind of come out the other side.
Absolutely. I'm just going to check. Stephenie, have we got you back with us? No, that's okay. We will hop on. The next question was one that I was actually going to put to Stephenie, so we'll wait for Stephenie to join us and just skip on. We've touched upon this, and I'll probably, it sounds as if Rebecca, you've not had to deal with this too much, so I'll open the question up to Alex, I guess, first of all. How do we deal with reluctant returners, so people who want to remain on furlough? And I'm sure there's probably many reasons why they might want to, but what's your thoughts on that, Alex? There we go.
Sorry, I just accidentally muted myself again. I think it's you know, if someone's reluctant, the first step is a conversation, right? You need to really understand and get to the root of why they're reluctant to return. If you know, I mean, you know, you've got your employer weapons, as it were, further down the line with processes and stuff if someone's being unreasonable. But firstly, you've got to see if it's reasonable, and you've got to explore it with them. So just have a conversation, you know, communicate, understand. And what you might find out is that it's a childcare issue. It's a medical condition that they've never wanted to disclose to you because they've been embarrassed about it. They've got an underlying medical condition and you just didn't know. So I think, you know, having a conversation with them, using something like in the handout section, I think we've got an example. We don't have the full one because we're not giving away the full one, but we've got an example of the return to work risk assessment we've done for team members. And it's a lot of going through, asking these questions, trying to get to the bottom of it. Even asking them, well, what could we? So similar to what Rebecca was saying, if you've given them your SOPs and you've explained it to them, and they're saying, I don't like this, then how would you like us to change this? What control measures do you think we could put in place for you? You know, having that conversation. If at the end of the day they're being completely unreasonable, then potentially that's a disciplinary route. But obviously that's way past have all the conversations. But I'd go down that route, and to be honest, you'll probably find that 90% of people you'll figure it out.
Yeah, absolutely. And that certainly seems to be what we're hearing when we do have people saying that they've got reluctant returners. Generally, if you're opening up the lines of communication, you're having those open, honest discussions with them as to what the problem is. Obviously, I think in dentistry, a large number of support staff are female. So what we find is we generally have more maternity leave to deal with than a lot of other industries, but also it does mean quite often that there's more childcare that we need to take into consideration. And at this time where a lot of schools aren't open to the vast majority of students, it is going to be difficult and problematic, and I think we just need to approach it with a more understanding hat on and ask questions, find out, get to the root of the problem, and allow people to discuss it. I don't think Stephenie's been able to log back in just yet. I'm sure our technical team is working on that. But for now, what we'll probably do until Stephenie returns is just move on to the Q&A section.